Thank you. It's a pleasure to be here. These are my financial disclosures. None are relevant. So to DSEK or DMEk, that is the question. DMEk, as we know, gives better vision, quicker recovery, less rejection, and better endothelial cell retention. Of course, we need to have patient considerations, how to choose the correct patient for either a DSEK or a DMEk. And all of these factors should be taken into consideration. What is their corneal status? Do they have previous corneal surgery, such as a PK, a glaucoma shunt perhaps, and of course the surgical view? For DMEk, cases of isolated endothelial cell failure, pseudophakic corneal edema, Fuchs, ICE, or previous PK, that tends to be my go-to. I tend to do DMEk in all of these situations. You want to be sure there's sort of minimal stromal edema or some unhappy DSEK patients. If the patient had a previous premium IOL, such as a multifocal IOL, and then developed endothelial cell failure, a DMEk is going to give them better visual acuity. More challenging cases, cases of previous vitrectomy, high myopes who have a deeper anterior chamber, prior glaucoma surgery, or if they need an IOL exchange at the time of your DMEk. It's also possible to do DMEk in these cases. Cases more appropriate for DSEK, if you have very little iris, whether it's aniridia or a partial iris defect or moderately large iridectomy, in that case, it's just make life easier for yourself and do the DSEK, aphakia, an ACIOL, silicone oil. Even if the retina person told you, they swear up and down that they got all the silicone oil out, you know that they are in fact lying. There's still silicone oil to be had. Do a DSEK, make your life easier. Glaucoma patients who have a tube in the anterior chamber, in that case, a DSEK is also preferable. DMEk, of course, requires a good view. And DSEK, you can do a DSEK even with a relatively cloudy view and poor visualization. After a previous cornea transplant, you need to know the differences between DSEK and DMEk. For DMEk, you do have to strip Descemet's membrane. Descemet's does not stick to Descemet's. You have to be careful of that graft-host junction. For DSEK, you don't have to strip Descemet's, although I usually do. And I always use about 1 millimeter smaller DMEk or DSEK graft compared to my previous PK. So if I'm doing a graft in an 8 millimeter PK, I choose a 7 millimeter. When you have a aphakia or you've got this is a patient who had previous trauma, had very little iris there. I did a scleral fixated lens, but I did what I call a stay suture, suturing the DSEK lenticle to the previous PK, and I'm glad I did because as you could see on the OCT, the only thing keeping that DSEK lenticle from being on the retina is in fact that stay suture. Unicameral eyes, it is notoriously difficult to get a good air fill, and so you want to keep that in mind. You also want to know if you have a failed DSEK, what was the etiology? Was it rejection, failure? Was there a problem with the surgery? And then you can decide whether to repeat with a DSEK or a DMEk. Patient with who's young, a phakic patient, if you have a good view and minimal comorbidity, then that's a great patient, again, for the doing a DMEk. This is a case of DMEk after DSEK. You'll see I'll go in there, and with this is a little MST forceps, I can just simply strip that DSEK right out. I do stain with blue in these cases because, as you could see here, there was a tag of Descemet's membrane that would be really good to remove if I'm doing a DMEk following a DSEK. And then here I'm using just the Gutter cannula. We're going to insert that. This was a deep anterior chamber, and so I use a lot of the techniques to get that DMEk graft opened here, and just again, just using some of those techniques for a deep AC where I narrow the AC, I tap it, I call it tap and trap, tapping it, trapping it, and we get the graft open, move it in place, and give an air bubble, and goes very well. With DSEK, if you have, again, a more challenging view, an anterior chamber lens, aphakia, or tube shunts. If a patient has previous glaucoma and has a previous glaucoma tube shunt especially, then that's somebody who probably want to do a DSEK on. I used to do DMEk on everything and everyone, and I switched actually in these cases to doing DSEK because these grafts don't last very long. They have maybe a 2 to 5 year, if you're lucky, life, and therefore rather than having the more expensively prepared tissue of DMEk, I tend just to do a DSEK. Also, they tend to have a more limited visual prognosis. This is a patient who had a repeat DSEK after a failed PK, an Ahmed tube, glued IOL. They basically had just about everything except for an RD repair, and hopefully they won't need that, but you can still get a good result. So in summary, how to choose a DMEk or a DSEK. For DMEk, you need a good view. I like doing them as procedure of choice in previous PKs or phakic patients. If there's a failed DSEK with minimal comorbidities, then DMEk is going to be a really nice option for you. And I save DSEK for my more complicated cases. Thank you so much.
If you have any questions from the audience, yes, sir. If you can stand up and speak loudly. If you can repeat the question for the audience who are behind him.
The question was, I believe, whether you do DSEK or DMEk for a previous vitrectomized eye. And I'd say if you're a novice DMEk surgeon, don't choose a vitrectomized eye as one of your first cases. But you can certainly do DMEk as long as there aren't a lot of other comorbidities. In a vitrectomized eye, you're going to have a deeper anterior chamber. And so you're basically going to need to do different maneuvers so that you can get that DMEk scroll open. You can also do a pull-through technique that Dr. Jodmet describes. That's also a nice technique as well. So there's a variety of techniques that you can use in a vitrectomized eye.
You should have come to our session yesterday morning. That was my presentation, correct? Just kidding, but it was the topic. But
yeah, I mean, there's a bunch of, I was about to say Tony gave a lovely talk on that yesterday morning. Essentially, you can do different techniques where you apply pressure, and then what you can do is you can then sort of tap and trap the scroll, and by tapping, doing a tapping technique where you kind of tap up, you release up, then you create kind of a little vacuum and you can get the scroll open. So there are several techniques that you can use in vitrectomized eyes.
So I have two quick questions, and it's both about for DMEk following prior keratoplasty. So in the setting of a prior DSEK that's failed, I'm doing DMEk, I often find there's sort of a fibrotic ring around the edge of the DSEK graft after I remove it. How do you size your DMEk grafts after DSEK? Do you see that fibrotic ring, and if so, do you want to have the graft fit inside of it, or is that something you haven't really seen in your DSEK failures? You'll just use whatever DMEk graft size you want, independent of the prior DSEK graft diameter.
In the setting of a previous DSEK, usually the previous DSEK is about 8 millimeters. I do measure it ahead of time because I'm going to pre-order my tissue. And so if you are pre-ordering tissue, I tend to order a smaller DMEk graft at 7 millimeters. And I find that in general, the 7 millimeter graft is going to fit in, because as I demonstrated in that case, there was a little bit of fibrosis, but also a little bit of Descemet's membrane that needed to be stripped there, as you know, which is important. And so that's what I do is I specifically order. We have the luxury of ordering from the eye bank to be able to size down, or you can just measure ahead of time and then decide on the size of your DMEk graft, but I tend to size down for that.
And then the second question, in the setting of a prior failed PK, do you ever use OCT to look at the posterior corneal profile? And if you don't see a step at the graft-host junction, do you feel comfortable going larger? You mentioned you usually undersize by millimeter, but let's say you have a small PK. Do you ever do OCT to say, oh, here I can actually have a DMEk graft that's the same size as the PK?
I do use OCT. I still tend to be a little conservative because even if on the OCT it looks fine, sometimes when you get in there, I find that it's not as perfect as you might think. And so I still tend to be conservative and size down.
So I guess the only time you don't worry about it is if it's a failed DALK. And I've had a couple failed DALKs. Then, of course, there is no, the posterior cornea is smooth,
Yeah.
non-functioning. So then you can do whatever size, whatever diameter you want. So great talk. Thank you very
Thank you.
much.